in 2014, and mother-to-child transmission of HIV reduced from 70,000 babies in 2004 to less than 7,000 in 2015. As you can see, these are remarkable successes, but you'll notice, Chair, that the successes are largely due to biomedical intervention. When it comes to the area of socio-behavioral intervention, it's still an uphill battle, especially in the age group 15 to 24-year-old girls and young women. In this age cohort, there are 5,000 new infections per week in 14 southern and eastern countries, but half of these occur in one country only, which is our country. Hence, the NDP objective of reducing the burden of disease, to have life expectancy of 70 years by 2030, and to have AIDS-free generation of under-20s, we need to announce two major plans. Number one, in September this year, we will remove CD4 count as an eligibility criteria for ARV treatment. It means we shall move to test and treat in line with the new guidelines released by the World Health Organization in December last year. Chairperson, please explain that you did not bar them from clapping hands, just from participating in the debate. Please, you did not explain that thoroughly.
Your members can clap.
In addition, we'll provide PrEP, or pre-exposure prophylaxis, to sex workers in 10 sex worker program from June this year. With regard to providing PrEP to young women, we'll start by learning lessons from demonstration projects on how best to provide PrEP to them before offering this intervention to all the vulnerable young women. These new programs will cost us an additional 1 billion rand on this year's budget, and we are very happy to announce that Treasury has made this money available, despite the harsh economic climate in which we find ourselves. The second major program I wish to announce today is a plan to deal with the young generation. I wish to announce that next month, the June month, the Youth Month, we shall launch a 3-year campaign focusing on girls and young women in the age group 15 to 24 years and the men who are infecting and impregnating them. This campaign will have 5 objectives. 1, decreasing infections in young girls and young women. 2, decreasing teenage pregnancy. 3, decreasing sexual and gender violence. 4, keeping girls in school until matric. And 5, increasing economic opportunities for young women to try and win them away from sugar daddies. This campaign will be a whole of government and whole of society campaign and led by young people. I'm pleased that 6 young people are my guests in the gallery today, and I'll ask them to stand up so that you can see them. I don't know where my 6 young people are. They are going to be champions to run this campaign to serve themselves and their generation. This campaign, please sit down, thank you. This campaign will cost 3 billion rand and will be made possible by funding from PEPFAR, Global Fund, GIZ or German Development Agency, and government departments. Honorable members, 16 years ago, in the year 2000, the world's largest conference on HIV and AIDS, the International AIDS Society or IAS conference, was held in eThekwini. We recall the images of the brave and sadly departed Nkosi Johnson, who made an impassioned plea for greater global attention to be paid to AIDS. This was also the conference that called for ARV treatment to be made affordable and available in poor resource countries. 16 years later, we are happy to know that we live in a world in which millions of people are on treatment, with the largest number by far in our own country. I wish to announce to the House that in July this year, the World AIDS Conference, International AIDS Conference is returning to eThekwini. There will be about 20,000 people in attendance, including heads of states. This time around, Honorable Chair, we have got a different story to tell. I would like to urge honorable members to consider attending this conference. As you heard earlier, the highway on HIV and AIDS also contains TB in it. Although TB deaths have declined from 70,000 in 2009 to less than 40,000 in 2014, TB still remains the biggest killer of all infectious diseases in our country and indeed globally. Since the screening campaign was launched on World TB Day on the 24th of March 2015 by Deputy President Cyril Ramaphosa, I am happy to announce that we have successfully screened hundreds of thousands of people in the vulnerable sectors of correctional services, mining, and pyromining communities. This year, we are focusing on 8 metros with the aim of screening 1.3 million people. In this instance, we wish to welcome the 4.2 billion rand grant from the Global Fund to support HIV and TB responses. Honorable members, as you may recall, together with the Right Honorable Nick Heppert, a member of UK Parliament, I co-chaired the TB Caucus, which is a forum of members of parliament around the world to join a global advocacy to eradicate TB. I wish to announce that the African Regional TB Caucus will be launched in July, also in eThekwini, and urge members of the House to join the caucus and also to support the launch. Honorable members, as I've said earlier, only 16 years ago, it was unthinkable to put so many people on treatment with ARVs as we are doing now. The price of ARVs was exorbitant. Lest we forget, it used to cost 10,000 American dollars just to put one person on a year's treatment of ARVs in the year 2000. If that was not strongly challenged, it means in South Africa today, for our 3.4 million people on ARVs, the country will be paying 510 billion rand. That is half the country's budget. It will have been totally unaffordable to treat people. Imagine how many people will have died. Imagine the collapse of the economy with so many young people dying. Imagine the collapse of the education system, the health system, and all social systems in our country. However, this horrible scenario was averted with civil society activists in both, when civil society activists in both developed and developing countries, joined by UN agencies, philanthropists, and government, ensured that the prices were drastically reduced. Of course, large volumes of generic competition also contributed to the reduction. Today, instead of 10,000 American dollars per annum, it cost only 67 American dollars per annum to put one person on ARVs. Unfortunately, honorable members, very unfortunately, that horrible scenario I've just described is back to haunt us after 1.5 decades. The horror scene is back not in the arena of HIV and AIDS, but in the new arena of non-communicable diseases, or NCDs, as I've said earlier, as well as drug-resistant TB. You are aware of the exploding prevalence of cancer around the world and in our own country. We have just moved in a circle, unfortunately. Just as the price of ARVs were unaffordable, cancer drugs are devilishly unaffordable today. If no drastic action is taken today, we are going to be counting body bags like we are at war. 2 years ago, I was regarded as exaggerating or outright insane by some when I spoke openly against pharmaceutical companies that were planning a price onslaught against us. I'm talking here of international pharmaceutical companies. Today, that onslaught, as I foreseen it, is here with us. If you have got breast cancer and you need to be treated with a drug commonly known as Herceptin, you must part with 500,000 rand. You must part with 396,613 for colorectal cancer. You must part with 960,000 rand for metastatic melanoma, cancer of melanin cells. You must part with 204,000 rand if you have got MDR TB, and 832,000 rand if you have got XDR TB. These are figures out of this world, which even those on medical aids cannot afford. But it's the reality that ordinary South Africans are faced with every day. Today, I have no option but to call the HIV and AIDS-like solidarity of all the progressive forces to force significant reduction in the price of these medicines. The global situation is so out of control, Chairperson, that the UN Secretary General, Mr. Ban Ki-moon, has established a high-level panel on access to medicines to deal with this issue. Due to the role that South Africa played in the fight for affordable ARVs, the Director General of the Department of Health, Ms. Precious Matsoso, has been selected by the Secretary General of the United Nations to be a member of this panel. Hence, she is not attending this budget. She's not attending this budget vote today because she's at the UN dealing with this very same problem. The problem got so worse that last month, Pope Francis entered the fray and convened a meeting of stakeholders to discuss this issue at the Vatican. He was worried about the morality of allowing people to die through uncontrolled prices. That is through uncontrolled commercialization of healthcare. This is what the Pope said, and I quote, "These patients, in fact, often are not given enough attention because the idea of profit prevails over the value of human life. It is fundamentally important to promote greater empathy in society so that nobody remains indifferent to our neighbor's cry for help, including when he or she is suffering from a rare disease," close quotes. Honorable members, the examples of pricing of healthcare I've given above is just by the tip of the iceberg to indicate how impossible it's going to be, or already is, for many people to survive major illnesses. Anybody who is desperate to remain alive and tries to obtain treatment at current cost will end up in poverty. Alternatively, governments will end up bankrupt trying to meet the health needs of their population. This disaster of unaffordable health care unfortunately affects people unequally. Those in higher socioeconomic status are better protected, and the unfortunate ones of lower economic status are left to perish. In the context of the World Health Organization in 1978, this is what the WHO said, and I quote, "The existing gross inequality in the health status of the people, particularly between developed and developing countries, as well as within countries themselves, is politically, socially, and economically unacceptable, and is therefore of common concern to all," close quotes. Hence, honorable members, the world of healthcare provision around us is changing very fast, and is changing radically. Those of us given the responsibility to take care of our people around the whole world are in a fighting mood to change our healthcare systems. In this fighting mood, we are driven by the spirit of no compromise and the spirit of no surrender. We want a fair, just, and equitable health system that will provide access to good quality, affordable care to individuals, regardless of their socioeconomic status. We are no longer prepared to tolerate very costly health care that takes care of only the elite, the famous and the powerful members of society, and ignore the poor and the downtrodden as if they've got no right to exist. Hence, with the powerful push and influence of the World Health Assembly, the United Nations has adopted the concept of universal health coverage as part of the 17 Sustainable Development Goals. In its preamble, it says it is an agenda of unprecedented scope and significance. In South Africa, our universal health coverage is called NHI, the National Health Insurance. Honorable members, politically, economically, and socially, how do we continue to justify a health system where 16% of the population, which is in essence the cream of the nation, have pulled their funds together in their own corner, away from the masses in the form of medical aid schemes only for the elite? Pulling these funds together for the cream of the nation means substantial resources, including human resources, are sitting in one corner, hiding away from the rest of society. Hence, today, we have got 80% of the medical specialists of the country being available to only 16% of the population, and leaving the remaining 84% of the population to struggle in long queues with only 20% of the remaining specialists. Today, we have some life-saving services being accessed by only 16% of the population. The poor are not even allowed to dream about them because they are not supposed to be meant for them. How do we continue to justify that you and I, here, honorable members, who call ourselves the representatives and humble servants of our people, together with the judges of our courts, who are defendants of the Constitution of the rights of our people, benefit from resources in a very expensive medical aid scheme of our own, for us and us only? How do we justify that? The same applies to all other professionals: teachers, doctors, nurses, policemen, women, engineers, lawyers, accountants, financial gurus, and all the cream de la cream of the nation, including those working in the private sector. Remember that this system is heavily subsidized by employers and taxpayers to the exclusion of the masses of our people. We can no longer continue to defend these unsustainable positions with flimsy arguments like claiming that there are a few taxpayers in our country, conveniently and deliberately forgetting that the poor pay heavy tax through a VAT on an everyday basis. We need to urgently change this state of affairs, and hence we want universal health coverage. We want NHI, where we will be forced to pull together funds for all South Africans, and all means all, not just a selected few. NHI is a political decision of a nation hungry for justice and equality. It is based on political will and should not be subjected to obstacles driven purely by greed and self-interest by a selected few. NHI is a reflection of the kind of society we want to live in, a society that will be based on values of justice, fairness, and social solidarity. It is not, NHI, it's not a beauty contest between the private and the public sector. As many who belong to this selected few like arguing. But it represents a desire.
Left, Minister. 2 minutes left.
It represents a desire to share so that the population can best utilize what both systems have to offer rather than centralize. Chairperson, we have got a number of projects which are in the pipeline, which unfortunately I realize I'm going to run out of time to mention. But to prepare for NHI, as Pope Francis has said, we can no longer continue to be indifferent to our neighbors' cry for help. So, as the white paper is saying, we have got lots of projects in our clinic, the ideal clinic model, the drug stock out model, but I want to mention one system here which is very important. For the rational use of medicine, it's called the STG, or the Standard Treatment Guidelines. It's an application we launched last year to help us on the point of care technology. It is freely available. It helps in decision making. It's not only for doctors and nurses. Even you as a member of the public, you can offload it. It will help you about telling you about side effects of drugs. It will give you direction to our health facilities. It will give you phone numbers. It will give you managers. But more than anything else, if you experience a drug stock out in a facility, you can press a button and it will report to us in Pretoria. As a member of the public, you can tell us that there are no drugs in a particular facility and will know immediately. These are some of the things that we are doing for NHI. The last two issues I want to mention, Chairperson, is that in 2012, together with the private companies, we launched what we call Public Health Enhancement Fund. And the companies are United Pharmaceutical Distributors, Alcon, Clinics Health, Joint Medical Trust, Medisco, Roche, Aspen Holdings, Discam, Life Health, MedScheme, Roche Pharma, Abbott Laboratories, Bosch Plus Lom, Discovery Holdings, Leader Holdings, Netcare Holdings, Sevia Laboratories, Abbott, Clicks, Galderma, MediClinic, Novonostics. They contributed 40 million rand for us to help build the human resources of the country. And we said with this money, we want to produce 1,000 PhDs in 10 years. I'm happy to announce that the first PhD in that scheme has been produced. He's Dr. Simon Nematandani. He's in the crowd there. He may stand up. And I'm happy to announce, thank you, Doctor. He's a product of this scheme with the private sector. I'm happy to announce that with this money, 76 more students are in the pipeline to obtain their PhDs.
Minister.
Lastly, Chairperson, I want to announce that as we strengthen the healthcare system, South Africa's first ever health ombuds has been appointed last week. He is Professor Maleraburu Makgoba. He will start as the health ombuds on the 1st of June, 2016. His function will be to investigate and dispose of complaints laid by patients and members of the public.
Your time is up. Thank you
very
very much.
I wish to ask honorable members to approve the budget of the National Department of Health to the amount of 38,566 billion. Thank you.
Honorable members, thank you very much. We had to allow the minister to conclude. Can I now ask Honorable Dundra, the chairperson of the committee?
Honorable House Chair, Honorable Minister Motsoaledi and his deputy, Honorable Pasha, members of the executive that are present, honorable members of this august house, our guests, abantu bomzansi Afrika, amaqabane nezihlobo, ndiyanibulisa. My budget vote is dedicated to all health workers of this country, irrespective of their category, from the lowest category to the highest category in the health sector. And again, I want also to say, on the 12th of March, it is going to be the International Nurses Day, but in particular to those nurses in South Africa. And that is why I think it is important that that is being raised. The Constitution of our country, which we have adopted on the 8th of May 1996, Chapter 2, Section 271A states that everyone has the right to have access to healthcare services, including reproductive rights. The Department of Health, together with its 5 entities, Medical Research Council, Compensation Commission for Occupational Disease, Council for Medical Scheme, Office of Health Standard Compliance, and the National Laboratory Services, presented to the committee their annual performance plans and budget for 2016-2017. It is that we stand here as the African National Congress that we support Budget Vote 16 of the Department of Health. Vote 16 of the Department of Health received 38.6 billion this year. This is an increase from 35 billion in the previous financial year, which they have got 2 largest programs, which is Program 3, which deals with HIV, AIDS, TB, maternal and child health, and Program 5, Hospital Tertiary Health Services, Human Resource Service Development, which constitute 92% of the total budget. And would like to congratulate the Department of Health, together with 4 provinces of health, Northwest, KwaZulu-Natal, Western Cape, and Limpopo, for obtaining unqualified audit opinion from the Auditor General. But we want to further congratulate Limpopo. We will all know where Limpopo is coming from, that they have moved to an unqualified audit report. The Department of Health will assist other provincial departments to obtain unqualified opinion. We are confident and bear testimony that the Department of Health has aligned its annual performance plan with the National Development Plan, the State of the Nation Address, and the Minister of Finance Budget Speech and other relevant policies. Yes, Honorable Minister, through you, Honorable Chair, that as the committee, we are confident that the National Health Insurance Program is really going to assist and ensure that everybody in this country, irrespective of class, race, and gender, is going to receive affordable health care. And we are happy that as your department, through you, Minister, that you have the National Health White Paper has been circulated for comment. Siyabacela kabantu bakuthi ukuthi balifunde liphepha. Kuthiwa yi-white paper, liphepha eliqinisekisa into kokuba i-National Health Insurance izakwenza into yokuba sonke sazi ukuba funeka sithini, yintoni na inxaxheba yethu, yintoni na ekufuneka yenziwe liziko lezempilo, ukwenzela into yokuba wonke umuntu olapha eMzantsi Afrika, wonke umuntu onemali uzawukwazi ukunceda ongenamali. So that is why it is very important that all submissions must be in by the end of May, and we are happy, Minister, that you have extended the date for submission for end of May. We want to congratulate the Department of Health for the introduction of Mom Connect. Kukinto abangayaziyo kabantu lento kuthiwa yi-Mom Connect. It's one of the most profound programs that have been developed by the Department of Health. I-Mom Connect ke ithi umama ozithwele esemakhaya esedorophini uzawuphatha ifoni yakhe axele ukuba ufike exesha liphina apha ekliniki, axelele i-department ukuba andihoyo apha, kodwa aphinda ayixelele i-department ukuba ndifike apha ngo-7 kodwa ndiphumile ngentsimbi yesibhozo. Kodwa ke, Minister, we really want to encourage you that you really look into the issue of the network so that all those that are in the rural areas are able to be exposed and be subjected to the Mom Connect pre and post delivery. Honorable members on mental health. Mental health is one of we congratulate the department for ensuring that it has developed some institutions that are to ensure that mental health, it's not about a patient being locked up in an institution. It is about an illness that everybody is subjected to. Those that are I have been doing psychiatry and physiology and psychology, they will understand that there's a very thin line between sanity and insanity. A very thin line. And not all of us here can stand up and be confident that they can never be subjected or be victims of any mental disorder. And therefore, it is therefore very important that, Minister, in all workplaces, even here in Parliament, we've got wellness programs that have got people that are more empowered to understand why we have got such, we have got disorders and tendencies that maybe at times are not of our own making. As the committee, we encourage that we empower the department empower community health workers on these skills, because community health workers are going to be able, as they are empowered, going door to door in their communities, to be able to identify those people that have got that at an early stage, those that are suffering may be suffering from mental disorders. But we think that there is a gap, Honorable Minister, in what is called pediatric and adolescent psychiatry. We are really requesting the department to look into that. We congratulate the Department of Health of completing 3 psychiatric units in the psychiatric hospital. These units are in St. Barnabas Hospital in the Eastern Cape, Chris Hani Baragwanath Hospital, Helen Joseph in Gauteng, where there are challenges. We encourage the department to address those. On human resource, we want to congratulate the Department on Human Resource that they have a program called WISEN, and the simplest way for people to understand, honorable members, WISEN is to put people with skills in the relevant places so that our people don't stand in long queues and waste hours because there is a mismatch and patients are not attended in a way that they are to be attended. We encourage. And we then say to the minister that, and the department that we want to ensure that as we are implementing in the process of ensuring that we achieve our goal of the National Health Insurance, these programs that have been introduced by the Department of Health are to show that happens. We request the Department of Health to accelerate the revitalization of nursing colleges. I'm standing here as a former nurse, a former health worker. It is for the first time that in this country, we have got a dedicated person that has been appointed by the Department of Health to look into the plight and everything that attained in the nursing fraternity, including infrastructure, including curriculum. We hope that Ms. Makasi, who is here with us, who is the guest of the minister, if I had a right to say, she must stand up for people to see, because nurses are the backbone of the health.
You may stand up, Ms. Makasi.
Makanya.
Makanya. Ayakako ungakubeke.
On Compensation Commission of Occupational Disease, presently the primary responsibility for regulating compensation, health and safety, compensation rests with the government department, Labour, Mineral Resource and Health. South Africa currently has got 2 statutory systems for compensation occupational disease. The Occupational Disease in Mines and Workers Act under the Department of Health, and the Compensation for the Occupational Injuries and Disease Act under the Department of Labour. In 1993, the compensation system was under Odimwa historically, did little to alleviate the heavy impact of occupational lung diseases on mine workers and ex-mine workers. It is of this reason that the minister, with the support of Labour and Minister of Mineral Resources, the Chamber of Mines and Trade Unions, is embarking on a process of integration of the compensation system so as to bring about a unified, equitable, and comprehensive compensation system for mine workers in South Africa. Through the leadership of the Minister of Health, the department should be encouraged on the bold step that they have taken in bringing a new management at the Compensation Fund and Medical Bureau of Occupational Disease. The establishment of one-stop shop centers is welcomed, and as part of the ANC-led government efforts to decentralize services, especially in labor-sending areas such as the Eastern Cape, additional centers will be built in Kurman, Beggarsfort, in this final year. The committee is, however, concerned about the CCOT non-submission of financial statement for the Auditor General. On NHLS, we are standing here confident that the Minister and the DG took a bold step in rescuing that institution. Because if it wasn't because of that bold leadership, we would have been having a crisis in this country in terms of all what the National Health Laboratory Services is to do. And we are confident that it is led by a CEO who is a female, whom, as the committee, we have seen that he has got an ability and capacity to turn things around. But we have got a serious concern, Minister, that when students passed in Technicon as medical technologists, when they are to write examinations to be admitted, they fail. We are saying to you, as the leader of that department, that must be looked into. We have requested the CEO to make an audit. What are the causal factors of those children when they have passed in the universities, but when they are to write examinations in NHLS, they fail? On South African Medical Research Council, the committee is happy with the research conducted by the South African Medical Research Council, particularly findings on cancer of esophagus in the Eastern Cape, in the areas of Butterworth, Mbizana, and Lusikisiki. We requested the Medical Research Council to reflect to us the causal factors of those. Ngumhlaza ke kaqhoqhoqho esifuna ukuqonda okokuba kutheni intoni lento ipha emampondweni ebangela into okokuba ithi le entity abantu abaninzi kufunyaniswa into abantu abaninzi e-Eastern Cape abanomhlaza womqala kulapho kusembizana. Yiyo loo nto ke sithe mabakhangele ngobunono ukuba ibangwa yintoni naloo nto. Council of Medical Schemes, we are saying the Council of Medical Schemes is doing very well, but we are concerned that there is, Minister, the delay in the employment of the registrar. But we are also concerned that they are very thin, weak on human resource in terms of the processing of claims. 7 people that are to process.
2 minutes left.
Thank you. 7 people that are to process 5,000 people. We want to say, apha kubantu bakuthi, ningayilahli imbo yenu ngophoyana. Kuba kaloku umbutho wesizwe, umbutho ka-OR Tambo, uthe kwi-manifesto, nakule ye-local government, nakwesi sihlandlo, siyazibophelela, into yoba sizawuqinisekisa into yokuba ezempilo kweli lizwe ziyatshintsha. Siyayazi kaloku into yokuba sisuka apho uburhulumente we had 15 legislations of 15 departments in this country before 1996. Kodwa sithi ngokuba sikhokelwa ngohloniphekileyo uqabane Honorable Minister uMtswaledi, sithi ke xa nisiya niyokuvota, xa nisiya kumaziko ezempilo, siyazi kanjalo into yokuba izinto azenzekanga ngokokuba sithanda kaloku zisenzile impazamo. Umuntu ongasebenziyo akazenzi impazamo. Kuba sisebenza, sizenzile impazamo, siyafunda, siyazibophelela into yoba kwezi impazamo esizifundileyo, kula mahlande enyuka esidibene nawo, kule mnqantsa esithe sadibana nayo singulo rhulumente, kuba kaloku if you have never been in the cold face of health sector, you will never know that there was a time in this country that a patient was treated on condition of his color, his race, a tablet, food, and even a blanket. I'm standing here, honorable members, bearing testimony because I'm a former health worker. I started working in the health sector as a general assistant, for your information, until I left. Thank you very much.
Time is up. Ngizawucela ilungu elihloniphekile uJames.
Madam Chair, Health Minister Aaron Matsaledi's greatest contribution to the nation's health is the HIV/AIDS antiretroviral program. Since he took office, Black lives in particular have been extended by multiple years. Credit is not his alone, Former President Kgalema Mothante's moral judgment in 2008 ended the long night of HIV/AIDS denialism by appointing former Minister Barbara Hogan, who first set our policies on the right course. Health civil servants, led by the capable DG Malabona Precious Matsoso, reversed the schizophrenic culture that pitted modern medicine against pseudoscience, beetroot, and garlic naturalism. But it is the minister's fighting spirit that led the charge against HIV/AIDS, as he has against TB, winning the USA TB International Award for their effort recently. So when the minister takes aim, members, stuff happens. And we, from this side of the House, applaud you for that, sir. Madam Chair, we all agree that we have not turned the corner in lifting our health burden. To summarize, there are infectious diseases, chronic illnesses arising from unhealthy habits, and the inevitable degenerative conditions of an aging population. Firstly, we are afflicted, as you've heard, with a high incidence of infectious disease, HIV/AIDS and TB in particular, for which there are no vaccines in the case of HIV and no effective vaccines in the case of TB. And these infectious diseases are showing no signs of burning out. We have between 6.4 to 6.8 million people infected with HIV/AIDS, the world's highest burden, but 3.26 million are on treatment. And therefore, the minister's program in rolling out antiretrovirals is very, very important, as you've heard. New infections have neither stabilized nor declined. There were 450,000 active cases of TB in 2013 and more than 26,000 drug-resistant ones. Secondly, the unhealthy habits of our nation are resulting in chronic diseases. Comparatively speaking, we have a high percentage of teetotalers in our country, but those who drink do so excessively. We eat fast foods and drink sugary beverages at a rate that make us the most obese people in Africa, while on the road to already alarming levels of diabetes, hypertension, and heart disease. 26% of boys and 52% of men are obese or overweight. 36% of girls and 82% of women are likewise. We are one of the great sporting nations in the world with extraordinary opportunities for exercise, but the majority of people, mainly black, have few safe spaces or accessible gyms to use. This is an overwhelming burden. If you look in particular at the third issue, which is an aging population that brings cancer, cardiovascular, and degenerative diseases. Madam Speaker, health is the second largest budget commitment after education, 157 billion rands and 182 billion if one adds conditional grants. And our health to GDP ratio is higher than the norm for middle-income countries. But Madam Speaker, the 2016-27 budgets before us do not honor our constitutional commitments as defined in Section 27, which read, quote, everyone has the right to have access, A, to healthcare services, including reproductive health care, and 3, no one may be refused emergency medical treatment. The minister should take aim at these two critical issues, but his budget does not reflect it. This is because the National Health Insurance, NHI, is all things to all people. Neither does the NHI projections meet the constitutional requirement, which is S 27.2, binding the state to take, and I quote, measures within available resources. The DA proposes a different route to universal health care. Please do not confuse NHI with universal health care. It's one model to get there. We are proposing a different route to get there by taking 3 key policy measures that will result in every citizen and every legal resident getting access to health care. First, universal access could be achieved in 1 year if the minister dropped the means test, if he brought the off-budget medical aid credits onto budget, and defined a universal subsidy for everyone. Medical aid credits, members, are worth 15.9 billion rands, sitting there as medical credits. Second, The Minister should strongly consider setting up a maternal and child care fund to finance, paid as conditional grants, the expansion of maternal and pediatric services at hospitals and clinics. This includes an extension of antenatal services and obstetrics care to rural and underserved areas in particular. Third, the Minister should create a national emergency care fund that would serve as an underwriter of all parts of the health system offering emergency services of any form. The fund's purpose is to give equal access to the nearest treating facility, regardless of whether the individual is covered by a medical scheme or the public sector. Madam Speaker, Madam Chair, the Minister is not the only one who must take aim. We need much more effective collaborations between national and provincial health ministries, civil societies, and let me say, smart, non-partisan contestations between political parties that elevate accountability to citizens as the highest principle of our land. Madam Speaker, accountability brings me to the subject of oversight. It is a constitutional imperative and duty for every member of Parliament, and it should be encouraged. One cannot do justice to a portfolio, especially one such as health, by sitting behind your desk. You must go and see for yourself. I once visited Charlotte and Kenge Hospital only to discover that Picketup's criminal unwillingness to collect ordinary garbage created a major public health risk. I alerted a very senior official of the health department, and the next day, honorable members, the garbage problem was attended to by this official. The department is highly responsive to oversight reports. In preparation for today's debate, I visited 2 clinics in Nelson Mandela Bay, 1 in Uitenhage, 2 clinics in a hospital in Durban, and 3 clinics in Mangaung yesterday. RK Khan Hospital in Chatsworth had no X-ray machines in casualty. The problem has been sorted out, I believe. But in probing the problem, I established that the tender process for medical equipment is paralyzed, and few, if any, of the life-supporting machines there have been serviced at clinics and hospitals in KZN. And by the way, Madam Chair of the committee, the Honorable Dunjwa, KZN had a qualified audit with 3 findings, and therefore you were quite wrong. I suggest you read your documents again. Yesterday in Mangaung, I established that the Free State government, in an effort to save money, failed to include extended service contracts in the tenders concluded with medical equipment suppliers. There is therefore no guarantee that anesthetic delivery equipment will work during surgery for patients there. But the Minister does not like my visits. I have news for you, Minister. Oversight visits help you. You appoint the key officials of the Office of Health Standards Compliance. Though they do very good work there, they are very mindful of not displeasing you too much. Your visits to hospitals, when they happen, are almost always announced, and therefore they prepare. I believe that you are out of touch with what is happening at our clinics and our hospitals. I challenge you to join me in a national program of unannounced visits. The effect of that, believe me, will be dramatic. Finally, our people must take aim. We need an incentive architecture to support our population to make smart choices, to drink less, to eat better, to exercise more, to avoid high-risk sexuality, to drive sober, and to adhere to norms of hygiene. In the national commitment, I make this commitment. The Democratic Alliance will work in the spirit of bipartisanship with the Minister and the Treasury to bring the off-budget 16 billion rands worth of medical credit aids on budget. It is a win-win scenario. Medical aid member contribution should drop. I'm wrapping up. It is a cross-subsidy. It is a cross-subsidy. It is a cross-subsidy between those who have jobs and are on medical aid and those who do not. Health justice will be served in this way. I thank you.
Thank you. Honorable Mhlongo.
The EFF rejects budget vote 16 on the Department of Health on the following.
Order.
The NHI, however good of an initiative, will not work under this government precisely because the necessary checks and balances were not conducted to ensure that the scheme will be fundable and that it will benefit the millions of our people who are currently not on medical aid. The government still has no idea as to how much this program will cost government when fully rolled out. This is a black box. The funding model remains a subject of speculation. The provincial health departments continue to get poor audit outcomes, especially in Mpumalanga province, due to irregular expenditure. The Free State Health Department has no doctors because of its long-standing problem of not paying its doctors. Specialists continue to resign in numbers into private sector. Gauteng province continue to experience a lot of problems with regard to overcrowding of secondary hospitals, and we still see patients sleeping on the floor. The emergency health services remain dysfunctional, with a lot of services being offered by private emergency services. Poor management of health facilities remain a huge problem. The 5 health entities do not really present a good story of progress, except NHLS, which shows significant signs of story of good progress and improvement. The South African Medical Rescue Council still has not addressed itself to the historical imbalances in allocation of resource and support to historical black institutions in conducting research and promoting black researchers. The CCOD has not been audited and has never presented itself to Parliament Health Portfolio Committee for a number of years. This entity has a lot of problems that seemingly are impossible for Health Department to resolve. This entity is seized, amongst others, to look after the most vulnerable of the community, which is the mine workers. TB in mines remains a big issue, especially the most extreme forms, that is MDR and XDR TB. The OHSC has no CEO and the Office of the Ombudsman, making it unable to develop concrete plans and programs to deal with its functions of regulating the health department, protecting the public. The department has not outlined a proper plan of rolling out secondary and tertiary healthcare facilities in addressing the huge numbers of overburdened hospitals due to exponential growth in population since 1994. We are still producing far less medical practitioners, leaving our public health facilities crippled by the demand for qualified health practitioners. The dishonest commitment of government to establishment of a state pharmaceutical institution is demonstrated by moving this function from Health Department to the Department of Science and Technology, where this issue will be relegated to a back seat. The same goes to the College of Medicine of South Africa, which frustrates many black medical practitioners who end up leaving en masse the country in huge numbers to get access to specialized education in other countries abroad. This is because of this government failure to apply systems and controls. The EFF remains concerned that, this is a reality.
Order, Honorable Member.
This is a reality, no
Order,
matter
Honorable
how
Mhlongo.
people can actually...
Honorable Mhlongo,
Yes.
order, one moment, there's a point of
Sorry,
order.
Chair, on a point of order, the Honourable Member across the way referred to the Honourable Mhlongo as a strange animal, and I would please like you to rule whether that is parliamentary.
Order. Which Honorable Member?
It was the Honourable Manana.
Manana, Honorable Manana, can you stand up? Did you mention the phrase as alleged? We will check on the Hansard and come back to the House. Thank you very much. Order. Honorable Njomane, can you continue?
No matter how much members, honorable members, we can actually then begin to make some
Point of order,
claims
Chair.
of progress.
Chairperson, point of order, please. Chairperson, I'm sitting here watching Honourable Manana call our members liars over and over again. I'm astounded that that sort of behaviour is going on in this House.
Order, honorable members. This debate has been going on well. Can we please try and make sure that we keep the decorum of the House as we should?
Sorry, Chairperson. I must rise on another point of order. The Honourable Member, and she's smiling because she knows what she did, referred to the Honourable Kola Barnard as a racist. Now, I would please like you to rule whether that is indeed parliamentary.
Order. 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 Which honourable member is that? Honourable members, can we please be in order and allow the House to proceed? We know that you can't cast aspersion on members. We also know what words are unparliamentary. We also know that if people want to bring a substantive motion, they should do so accordingly, not to make allegations. Can we please be in order? Honourable Njomane, can you please continue?
Thank you, Madam Chair. Madam Chair, as economic freedom fighters, we are, however, clear that our presence in this very august House does not necessarily mean that we will, at any given stage, seek to massage the ills and the evils of the past that were afflicted to our people, because that did not by accident happen. It was through design and through some kind of well-designed methods as to how many people of this country, particularly the indigenous African
Honourable
people,
member, your
would
time
have
is
to
over.
suffer. It is on this basis, therefore, that we say we reject this budget vote.
Order.
And we are going to ensure that even when we take over, then the people of South Africa will then enjoy
Thank you, honourable member. Your
free
time,
health service
your
delivery
time is up.
to all of the people, not only those who are covered in the medical aid. Thank you very much.
Order, honourable members.
But
Honourable member,
Honourable Chair, may I just raise my own point of concern?
Order.
You know, Honourable Chairperson.
Order. Honourable
Honourable
members, can you allow the chair to regulate the functioning of the House?
Honourable Chair, in any civilized society, debate is a bone of strength. But to begin to make howling and begin to insult those who are actually... No, please.
Order, honourable members.
I've never said a point of order. No, please, keep quiet, please.
Honourable
Please,
member,
ma'am.
I've heard the point of order. Thank you very much.
If you can please call your members to order.
I will.
I don't like
Can
to
you
be
please
howled,
take a seat, honourable member?
and that lack of discipline is actually undermining
Order.
them. And I will never give them respect. Thank you very
Order.
much.
Honourable members. Honourable members, I requested you that allow the chair to manage the House. I have allowed members on both sides of the House to conclude their points, giving them an extra second or even an extra minute. I don't think it is fair for any of us, if we are not happy about someone's intervention, to then try to rule from our seats to say people must take their seats before the chair do so. I really would appeal that we go back to the decorum that we started with this debate on. People would want to hear engagement on the policy statement of the minister and the budget on what, as you as members of this House are saying to it. Secondly, I want to indicate that smaller parties may not be in all committees, and we know that. So if a party chooses any of its members to participate in a debate, it cannot be correct for any of us to then say a party, because they don't sit in that committee, either regularly, must not participate in the debate. I just make that as a common point, because there are some parties who only have got one member in the parliament. So they will participate in debate as and when they are able to do so, or in any committee. I just thought I needed to make that point. Honourable Member, you wanted to rise on a point of order?
Thank you, Chairperson. For the second time in succession, the Honourable Manana again referred to the Honourable Mhlongo as an animal. Now, I submit to you that it is not parliamentary and, in fact, cowardly.
Order. Honourable members, there is only one Honourable Manana, not all of you.
And, in fact, it is cowardly to shout it across the room, but then not take ownership for it. And, Chairperson, I mean, we can all hear it across the floor. Surely you should be able to do so. And I please ask you to rule on the member to either, take ownership for her comments, or she should actually withdraw the comment or withdraw from the House.
Honourable McPherson, I was dealing with the issues precisely because there was such commotion. So there was no way as a chair I would have heard which member said what at what point. And I would respectfully ask all of us again. I won't take the point of order, Honourable Member. I would actually allow us to continue with the debate, and can we please respect ourselves? Can I now ask Honourable Singh to proceed? Honourable Member, with an iPad, you can't use it. We ruled on that last week. It's used for particular purposes and not for the purpose that is not intended to in this House. Thank you. Honourable Singh, can you proceed?
Thank you very much, Honourable Chairperson, and thank you for not allowing this to degenerate into an unhealthy debate. It's a very, very important topic for millions of South Africans, and I think we need to maintain the decorum and dignity that it deserves. Having said that, Honourable Chairperson, let me say right at the beginning that the IFP supports this budget vote. And we do so because we sincerely believe that millions of people in our country have access to healthcare services that they did not have prior to 1994. What is in question, though, is whether we are giving them quality healthcare services. And from what we read in what's happening in some of the provinces, KwaZulu-Natal, the rate of absenteeism, the lack of infrastructure, organizational issues, I think, Minister, with the passion that you and your Deputy Minister have and your department for health in South Africa, it's about time that you use powers in the Constitution, Section 101, to intervene in provinces that are not carrying out their mandate to ensure that everybody is afforded quality health care. I just want to follow on the Honourable Chairperson of the committee when she spoke about psychiatric hospitals. And my own daughter is a specialist psychiatrist. And she was telling me on the weekend how mental health has improved considerably. Access to mental health care has improved considerably over the years. And I think that's a good example of the passion that your department has. Having said that, Honourable Minister, I think the one area we need to look at is making sure that people who are born in South Africa and want to become medical doctors are given the opportunity to study here and to come back here and practice as doctors. Now, we know there are limited spaces at our medical institutions in the country. We know that there are certain criteria that are applicable to accept medical students to go and study in their first year. We accommodate SADC students, we accommodate students from rural areas, etc., etc. But that means that there are a number of students who get grade A passes, excellent passes, and who want to study medicine, who are forced to travel abroad, to the Philippines, to China, and everywhere else to study medicine. Now, what we need to do, Honourable Minister, is to make sure that the HPCSA regulations are such that they can... That they can... 2 minutes. That they can identify institutions abroad that we can accept their standard of qualification and make it easier for them to come back to South Africa. I want to dedicate this 2 minutes, Madam Chair, to the late Honorable Ambrosini. We know on the 19th of February 2014 he made an impassioned plea, and amongst other things he said, Honorable Minister, there is no rational argument for continuing to deprive medical marijuana to people like me who need it. This was followed with a private member's bill that was supported by many, and I think the President himself, the President of the country, indicated to all of us in the House that we need to take this up further. Now, we know, Honourable Minister, that the bill has surfaced before the committee. There have been a number of issues that the Medical Research Council and others have raised. But I think we've reached a point now when we owe it to the millions of people out there who need palliative care with diseases like cancer, glaucoma, and other diseases that afflict them. We need to, and we are going to be the first ones to say as the promoters of the bill, let us redefine the bill and remove all references to trade and hemp and recreational use, etc., and confine ourselves to medical innovation. Many countries around the world are already allowing the use of these products for medical care and for palliative care. I think we should be amongst those leaders in the world that should allow this. And we are prepared to move an amendment, Honourable Minister, and we know you have the passion to accept this amendment. Even if you feel that there is legislation that you currently have that can be amended with a one-line amendment, let us do so in the interest of the millions. And let's forget all references to trade and everything else for this moment in time. I think we owe it to the legacy of Dr. Ambrosini, we owe it to the President of this country that we do what he has asked us to do, and we owe it to ourselves and future generations that we actually get this bill passed sooner rather than later.
Thank you very much, Honourable Singh. Honourable Sheikh Imam.
Thank you, Honourable House Chair. Minister present, Deputy Minister, the Department of Health, colleagues in the gallery, honourable members. The National Freedom Party supports Budget Vote 16. We welcome the dramatic increase in the
contributors to this non-communicable disease due to obesity. In this regard, we have in 2015-2016 adopted a 5-year strategy for the prevention and control of obesity. It is within this ambit that we welcome the Minister of Finance introduction of tax on sugar-sweetened beverages in the budget speech in February early this year. We remind honourable members and the country that the WHO recommends that free sugars should only constitute less than 10% of total energy intake per day. For practical purposes, just to remind members, a 330 ml can of fizzy drink, which is equivalent to 8 teaspoons of sugar, is enough for the entire day's sugar need for our bodies. So if you take 1 can of fizzy drink, don't take anything sugary anymore for the whole day, not even a fruit or anything which has got sugar. Free sugars do not only contribute to obesity, but also to dental caries, especially amongst children. Honourable Chair and members, we remain focused on the important intervention of screening for NCDs for early detection. We have integrated our screening for diabetes. I had honourable member complaining about that we are not attending to diabetes. We have integrated screening of diabetes, hypertension with the mass HIV counselling and testing program. It was encouraging earlier this year to see scores of young people queuing to be screened at the Youth Career Expo hosted by the Deputy President in Soweto. We are currently working with the Innovative Pharmaceutical Association of South Africa, which is made up of 25 pharmaceutical companies, to improve our screening process, and I wish to thank them for their contribution. We also wish to thank all NGOs and private companies who are making a major contribution to our fight against non-communicable diseases. One area which is still under-resourced, which we are increasing services on, is screening for mental health. I appreciate the congratulations by Honourable Singh in terms of improved access to mental health, but we believe we must do more. In April this year, the World Bank and WHO hosted a joint meeting where the need to invest in detection and management of depression and anxiety was highlighted. We need to allocate more resources in this area. In terms of the Criminal Procedures Act, the Child Justice Act, and our own Health Act, our department has particular responsibilities in relation to offenders with alleged or established mental illness. As a result of capacity constraints, there are still long lists of offenders awaiting mental observations. Many of you will remember the famous Oscar Pistorius story, who had to jump a queue, and also state patients waiting for beds. In March this year, 921 detainees were awaiting mental observations, and 181 state patients were waiting for hospital beds. To discuss solutions, we had a seminar early in March this year. From this meeting, it was agreed to review certain legislations, revitalize more of our institutions, and improve skills. Cancer remains one of the leading causes of death in our country, especially breast and cervical cancer amongst women, and prostate cancer for men. 3 years ago, the minister appointed an advisory committee on cancer. After consultation, this committee has almost completed a new policy and strategy, as well as policies on specific cancers such as breast and cervical cancer for adoption. Their review of cancer research shows that we need to do more on health promotion and health systems. With regard to availability of services, their survey found that there are large parts of the country with very little or no cancer services. The term of this committee has come to expire, but we have extended it by another 6 months, and I want to take this opportunity to thank them, the chairperson, Prof. Suram, and the deputy chair, Ms. Asante Shongwe, for their diligent work in this regard. Honorable Chair, we have long recognized that our services for people with disabilities and for rehabilitation were not adequate. While there has been some improvement of access to facilities, we believe there's still a lot which needs to be done. We have now adopted a strategy called the Framework and Strategy for Rehabilitation and Disability Services 2015-2020, which will be implementing together with our colleagues in the provinces. Honorable members, with regard to malaria, our department is still focusing on elimination, which will mean 0 new cases. Malaria cases were reduced by 57%. From 1,487 to, from 14,000 to 6,000 cases. And deaths were reduced by 74% from 200. Not afford complacency, we will identify exact geographic areas where malaria transmission is still occurring and apply the strategies which are approved by the WHO, which include indoor residual spraying in order to make sure that we can eliminate malaria. I'm also pleased to report that we have signed a declaration with Mozambique, an organization or a structure called MOSAWA, which is Mozambique, South Africa, Swaziland Initiative. The goal of this initiative is to accelerate the transition from pre-elimination to elimination of malaria in the 3 countries. Honorable members, we are making progress also in our quest to improve nursing services, and the Honorable Chair has already alluded to that with the appointment, amongst others, of the Chief Nursing Officer, to improve education and practice of nursing. The National Strategic Plan for Nursing Education and Practice has elicited a number of comments. A national policy for nursing education and training is currently underway. The policy seeks to address, amongst others, the following: provide a framework for the standardization of the management and administration of nursing education nationally, to address issues of curricula for the new nursing courses, to ensure that the right caliber of nursing students are recruited and selected into the profession. Our target is to make sure that this new policy is implemented latest by the year 2019. Honorable Chairperson, we remain very grateful for the Nelson Mandela-Fidel Castro bilateral agreement on health, which is now in its 20th year. We are celebrating 20 years this year of this agreement. Through this agreement, South Africa enjoys the services of Cuban specialists in remote and rural areas where in many cases our hospitals and even teaching institutions are highly dependent on them. We currently have more than 319 Cuban doctors in service as compared to just under 200 the previous year. The South Africa-Cuba medical training program is growing strength to strength and has to date, since inception, produced 518 doctors to our country. This number includes an injection of 55 doctors who completed at the end of 2015 and will be graduating 2 months from now in July at the University of Witwatersrand. That's where the graduation will be held. There are currently 110 final year students in our local medical schools completing their studies because they do 5 years in Cuba and complete the final year here in South Africa. Currently, we have just under 3,000 students pursuing medical training in Cuba. In the second half of 2018, we will receive more than 800 final year medical students who will be absorbed into our local medical schools to complete their studies. More than 800. That's almost more than half of the entire medical student training in South Africa presently. At a go, we'll receive 800 who will be finalizing their studies here. We are working with all the medical schools and departments of health to ensure that we have the capacity to absorb all of them into the final year training. We see this as a good challenge to transform the orientation of our own training of medical schools and expand their training, expand the platform, because our medical schools are still very much curative. So we believe with many more students from Cuba coming here, we will also have an opportunity to transform into a primary health orientated training. During the financial year 2015-16, an assessment was done of the current capacity of our central hospitals, which led to the development of an organizational structure to address some of the shortcomings. For this financial year, 15-16, the past financial year, in addition to Steve Biko, Inkosi Albert Lutuli, and the Groote hospitals, which are fully compliant with our national core standards, we also have some few other hospitals which are also doing well, which have been added, such as Grace Hospital in Maritzburg, Kalafong Hospital amongst the tertiary hospitals, which are also doing very well. But we intend to add in this coming few years a lot more hospitals which can also come in to make sure that they can meet the basic core standards. We have the regulations which are governing the promotion of emergency medical services are currently being rolled out, and this will be implemented in this coming year, including the improvement in the training of our emergency health workers. Our forensic pathology services, honorable members, have also been improving. I'm pleased to also just mention that an area which has been a lot of frustration, especially to our law enforcement, that of our chemistry laboratories in terms of dealing with alcohol, testing of alcohol analysis, which is very important in terms of conviction for drunken driving, that the capacity has improved with the addition of a laboratory in Durban, which means that this will be able to be concluded and cases will be able to be adjudicated in courts much quicker. The entities which report to the department, some of them honorable members have already mentioned, so I will not go into a lot of details. In as far as the NHLS, just to mention that we are looking at changing, adjusting the reimbursement model, because currently we're using the fee for service, looking at different model which will make it more sustainable so that our provinces don't have to be paying for each and every sample and every test which is being done. In as far as the National Public Health Institute of South Africa, honorable members of the committee will be familiar with the fact that we have tabled a bill in this regard. The Council for Medical Schemes, Honorable Chair has already alluded to it.
Time has expired, Minister.
Honorable Chair and members, we wish that this Honorable House should support the budget vote of the Department of Health. Thank you very much.
Thank you very much. Honorable Dudley.
Thank you, Chair. It is a fact that health demands always exceed available funds, even in more established and richer countries. And although the allocated budget this year is 168.4 billion, an increase of 11.1 billion, we will be hard-pressed to meet the needs in this sector. The ACDP appreciates the Minister and his department's dedicated efforts to provide an equitable, effective and affordable health service. Many nations do, however, spend far less than we do and have the same and better outcomes. Respected health systems expert Mark Britnell, formerly with the British NHS, says that having worked in more than 60 countries, from a provider's perspective, a common three-step process can be found behind many of the world's most efficient hospital systems. From India to the USA, the first step is to standardize clinical workflows by defining best practice, developing explicit guidelines, and making sure these are consistently adhered to. The second is to develop IT systems that cement these practices into the everyday work of staff, making best practice the default choice. The third step is to change the skill mix so that highly skilled professionals are only used for their expertise and other workers take the strain of routine care and patient management. In 2013, Singapore made relevant changes and has remained one of the world's longest living, lowest spending health systems despite a rapidly aging population, and it's worth a closer look. Healthcare in Israel also stands out as a tech-savvy primary care-led service and boasts a national average life expectancy of over 82 years for just 7.2 of GDP. Care for the elderly is globally acknowledged as an urgent priority as life expectancy has increased significantly. In South Africa, the population of people over the age of 65 is expected to jump from 3.1 million in 2015 to 5.6 million by 2050. Population aging affects many aspects of public life, from pensions and housing to acute and long-term health care. Japan in the year 2000 recognized the threat that elderly needs posed to its health system and took action by placing a 1% to 2% income tax levy on over 40s to pay for a national aged care service that funds home, community and residential care for all citizens on a means-tested basis. While this was a costly decision in the short term, in the long term it has prevented untold admissions to hospital and preserved the health of what is now the world's oldest population. Professor Pretorius of the University of Pretoria, commenting on cardiovascular health, Alzheimer's and Parkinson's, has raised concerns regarding South Africa's ability to cope. Professor Pretorius co-authored a paper on Alzheimer's research which revealed a need for a more serious look at a growing body of evidence pointing to the contribution of microbes in the development of Alzheimer's. She says the reason there is no treatment for Alzheimer's yet is that scientists have yet to know what to treat. The ACDP calls on government to increase funding for this important research, as it will affect a great many of the 5.6 million elderly people in South Africa by 2050. And impact on our health budget. Reliable data is essential. The ACDP welcomes the additional 740 million rand which has been allocated to strengthen TB programs and encourage early detection and treatment, and the 1 billion for expansion of the antiretroviral treatment program. We appreciate the dangers of TB and the growing challenge of drug-resistant forms of the disease. The ACDP notes a new study on a low-cost, easy-to-use urine test that could diagnose TB among patients with HIV and thereby significantly reduce the TB death rate of HIV-positive patients. We applaud actions to increase access, quality medicines, diagnostics and vaccines. Although the world does not have an HIV vaccine, research has been underway for many years, and much of it is built on work that is happening in South Africa. All provinces face challenges in the health sector, but an audit conducted in the Eastern Cape in 2011 showed major problems in terms of standards. And the report revealed what the ACDP, to wrap up, or a minute?
Please conclude.
The ACDP appreciates efforts to address these problems, but calls on the Minister to ensure better inter-department coordination and increased monitoring of standards and management performance. The ACDP will support this budget, which continues to face many challenges. Thank you.
Thank you, Honourable Dutch. Honourable Ndaba.
Thank you, House Chair, Honourable Minister and Deputy Minister, Honourable Members, distinguished guests, Bahlali baseMzansi, good morning. It is my honour to be part of this important debate of 2016-17 Budget Vote 16 at this time where we celebrate 22 years after the inauguration of the late President Mandela, which we give full support as the ANC. Prior to 1994, our health system was characterized by fragmentation based on racial segregation and discrimination. Since the advent of democracy in 1994, health provision in South Africa has gone through several radical transformations. These have been based on integration at primary healthcare level, respect of human rights, and an emphasis on prevention and health promotion as envisioned by the Freedom Charter and the strategic objectives of the National Democratic Revolution to create a loving and democratic South Africa. It is pursuant to the ideas of the Freedom Charter that our Constitution in Section 27 explains and elaborates the universal right of access to health care. This section, being part of the Bill of Rights, enjoins our government to respect, protect, promote, and fulfill the right of access to health care. The ANC Mangaung National Conference 2012, the NDP, and the ANC Election Manifesto 2009 are reconciliatory and not contradictory. They have the same vision, commitment, and common position in relation to the provision of healthy system that works for everyone. It produces positive health outcomes and is accessible to all. Chairperson, allow me to say it rose, it's alive, and it is leading. Sishoda ngawe. Allow me to quote Nicole Machiavelli, and I quote, "Once problems are recognized ahead of time, they can be easily cured. But if you wait for them to present themselves, the medicine will be too late, for the disease will have become incurable," I unquote. That simply says to us, let's not allow this disease from other parties to infect us, because it might be diagnosed but not cured on time. In reducing maternal deaths, child mortality, and promoting women's health, the ANC government committed focused programs in reducing unwanted pregnancies, contraception, and family planning, and introduced the subdermal contraceptive device. The device is inserted by a medical professional under the skin of the upper arm. This device costs 1,700 if you go to a private doctor, but we are giving it for free to every woman in South Africa. In reducing cervical cancer in girl children, all grade 4 are vaccinated against the virus which causes cervical cancer. Therefore, we advise parents to allow their kids to go to the nearest CHCs to access those free services from their caring government. In addition to that, our own caring government, to prevent unwanted pregnancies, HIV and AIDS, STDs, government is providing free condoms and ARVs. With all the efforts that the ANC government has done, there comes a person calling himself a future leader of the future leading party, encouraging our young black women to have lots and lots of children without fathers, for them to be able to have grants and houses. That will lead us to have increased STIs, HIV/AIDS, orphans, street kids, and irresponsible citizens. That's irresponsible of you, Julius Malema. Voting EFF unless, honestly, you'll be applying to be a street kid with no direction. The ANC congratulates the Honorable Minister of Health and the Department of Health.
Honorable your cousin want to pose a question.
Point of order, Chairperson.
Honorable members, please, let us
Point
allow
of order,
him flow.
Chairperson.
Please.
Honorable Chair, I'll request the member to refrain from useless and helpless propaganda.
I waste this cat someone. The ANC congratulates the Honorable Minister of Health and the Department of Health on the good work done in improving the lives of all South Africans.
No,
Yeah,
Chairperson.
no, Honorable Ndaba. Honorable members, let us not
Point of
harass another
correction,
member.
Chairperson.
Let us not harass another member. Let
We
us
must-
allow him to express himself.
Uthini?
Honorable Ndaba, take your seat. Ngoba usungena emgodini omkhulu manje. Ngithi ngiyazama ukukhipha. Honorable Ndaba. Honorable Mhlongo, please.
Thank you, Chairperson.
Are you raising a point of order or not?
Yes, a point of order, Chairperson.
What is your point of order?
My point of order, Chairperson, is a distortion of fact raised by President Julius Malema.
Thank you.
That the member must be cautioned not to grandstand on a useless.
Sit down, Honorable
propaganda
Mhlongo.
point. Thanks.
Honorable Mhlongo, sit down.
Voting on EFF, honestly, you will be applying to be a street kid with no direction. The ANC congratulates the Honorable Minister of Health and the Department of Health on the good work done in improving the lives of all South Africans through the delivery of effective, safe, quality, personal and non-personal health interventions for all South Africans. We continue to recognize, protect, and promote health as a basic and a fundamental right, human right, for every human being and all South Africans. It is to this end that we wish to reassure South Africa and the people that the ANC-led government, through the leadership of the Honorable Minister of Health, Dr. Aaron Motsoaledi, has performed well in service delivery on the following programs. The ANC government has also increased access to antiretroviral therapy to be the largest rollout program in the world, with people receiving antiretroviral drugs. Improved access to ART source Johnson LF 2012. President Zuma, in his State of the Nation address, noted Kitlapela, a state-owned pharmaceutical company that has been established and will participate in the supply of ARVs to the Department of Health in the 2016-2017 financial year as being a noteworthy advance in capacitating the state. The HIV incident is steadily declining for the past 12 years. Since the HIV counseling and testing campaign was introduced in 2010, over 35 million people have been tested. And as a result of the treatment program since 2004, there has been a reduction in the number of sick or dying people due to HIV and AIDS between 2004 and 2014. In 2004, AIDS-related deaths were 344,141, and in 2014, the number reduced to 171,733, according to Stats SA. 750 million male and 16 million female condoms were distributed in 2014 and 2015. Furthermore, over 1.3 million male condoms and 35 female condoms were distributed in correctional facilities. The government's HIV policy turnaround strategy since 2009 currently funds ARVs for 3.2 million South Africans, making it one of the largest in the world. HIV mortality incidence estimates and the number of people living with HIV, 2004, the source, Statistics South Africa. You can go and check. Incidence and behavior survey released in April 2014, maternal and child morbidity declined due to PMTC. Campaigns such as Prevent, Avoid, Stop, Overcome and Protect remain critical to new and innovative prevention programs for HIV and AIDS and TB. Vulnerable...
Chairperson,
uyambona lo muntu lo ungwesiphelisa isikhathi.
asamuzwa ngisho nokhulumayo Chairperson. Odadewethu ngalaba lo bethi free condoms. Kodwa abasho nanokuthi free shower.
Mhlongo.
Waphela bona namakhondom basebenzisa amashower.
Ona Mhlongo. Baba Mhlonisho. Awuzukuphakama phela noma nini nje mawuthanda ukuphakama. Okay, no. Nawe Mhlongo, musukwenza into engenziwe eParliament. Ungayenzi kanjalo.
Voting EFF is a disgrace, man. Yo. Vulnerable groups such as sex workers, campaigns such as prevent, avoid, stop, overcome, and protect remain critical to new and innovative prevention programs for HIV/AIDS and TB. Vulnerable groups such as sex workers, the lesbian, gay, bisexual, transgender, and intersex community, women and youth are strategic priorities. To this end, in March 2016, the Deputy President launched the National Sex Worker HIV Plan to fight against the HIV/AIDS, which will target over 70,000 sex workers with 3 years. The Department of Health, led by ANC government, has taken the bull by its horn and implemented TB prevention and treatment programs in line with the National Strategic Plan on HIV, STIs, and TB 2012-2016 and the NDP. And as a result, positive results have started showing since we have steadily decreased the number of new TB cases. Yeah, ne? Again, honorable members, how many minutes?
Uselena 30 seconds.
In September 2014, the official opening of Dr. Harry Surkip Hospital in the Northern Cape and the Natal Spade Hospital in the Gauteng were an important milestone in the country's infrastructure. In 2014, 9 Gauteng hospitals and 3 pathology facilities received new X-ray machines that have scanned trauma patients with 12 seconds and improvement in the existing machine. And the machine costs 60 million. When I'm strong.
Honorable Ndaba. Ungasukela Honorable Mhlongo. Honorable Mhlongo must be protected. Please, Honorable Ndaba. Ungayingena Ndaba baba Mhlongo. Honorable Folmer.
Honorable Chairperson, one of our nation's most vital resources is its health workforce. And the budget reflects this, allocating 2.5 billion rand to HIH planning under Program 5. However, while funding is important, what is as essential is that our health professionals are adequately supported. Moreover, action needs to be taken against anyone who would interfere with the support without fear or favor. It is within this context that we ask the Minister to take bold action on the issue of the Health Professionals Council of South Africa, or the HPCSA. The HPCSA is supposed to play a pivotal role in providing a capable health workforce. In short, it's supposed to balance professional freedom with safe practice so that both providers and the public are protected. However, it has failed abysmally in its duties. In November last year, a ministerial task team led by the highly respected Professor Mayosi, released a damning report on the HPCSA entitled The Case of Multi-System Failure. The findings included 1, that the CEO was implicated in, quote, acts of unauthorized, irregular, or fruitless and wasteful expenditure, unquote, involving an Oracle IT system. 2, that the registrar had severely mismanaged the HPCSA. This included the failure to register health professionals and recognize foreign qualifications, and 3, that the general manager of legal services had failed in dealing with professional misconduct cases, potentially deferring justice for victims of medical negligence in the order of years. Now, I've been approached by many of these individuals, and I've got a list of cases here, and it includes a young doctor who trained overseas, came back, completed successfully his internship here in South Africa, and then was told, for no justifiable reason, by an official from the council that he should either change his career now or leave the country. Now, this isn't a doctor who is unfit for practice. This is a highly skilled doctor who followed every prescript of the HPCSA, and yet he's been sitting at home for years now, desperate to deliver services, but unable to do so. There are also tragic cases. These are tragic cases of citizens whose loved ones have been harmed through alleged medical negligence, but whose complaints have been callously unresolved by the HPCSA. And this is an issue that can affect any one of us here. Although the April deadline for an implementation report from the HPCSA has come and gone, the DA will not rest until the council is brought to account. And while we note the resignation of the registrar, the Dr. Mjamba Machoba, it's not clear if she faced any consequences for her misconduct. Furthermore, to expect the current council members to restore the fundamentally and irreparably damaged image of the HPCSA is frankly unfair to them and members of the public. So we urge the minister to act. While the HPCSA has some independence, the Health Professions Act gives the minister the power to dissolve the council. Therefore, we ask the minister again to act in accordance with the MTT report and 1, ensure that proper disciplinary action is taken against all those involved in the dismal state of the HPCSA. 2, ensure that an impeccably ethical interim executive team is firmly put into place. And 3, to replace the now broken HPCSA with 2 new councils recommended in the report. Furthermore, we call for the setting up of service centers to deal with the massive backlog of both professional misconduct cases and registration complaints that require urgent and fair resolution. To the point, and in summary, as substantial as the HRH planning budget is, its benefit to the health workforce will be obstructed by the albatross that is the HPCSA. And so we would ask the minister to step up here and display decisive leadership for the sake of the health professionals and the communities that they serve. Thank you.
Thank you very much, Honorable Foreman. Honorable Matlalela. Honorable Chairperson, Minister and Deputy Ministers, honorable members, comrades and friends. It is a known fact that the efforts towards the universal healthcare in South Africa started as far back as 1920s, which resulted in the establishment in 1944 of the National Health Commission, also known as the Klukman Commission, which recommended a national health tax so that health services could be provided at a point of service for all South Africa free. The 1994 democratic breakthrough provided an opportunity of the people's government to unify the country's health system by dismantling the apartheid design institutions and to ensure greater equity in access to health services to all without regard of race, color, or social status. It is a known fact, Honorable Chairperson and members, that 22 years into our democracy, health inequities continue to be a feature of life of our country, where only 16% of the population are covered by a high-quality private healthcare system, which was publicly confirmed by the World Health Organization's submissions on the Competition Commission's health market inquiry into the cost of private health in South Africa, which was said to be very, very expensive. The WHO noted that based on the evidence that they presented, South Africa has the most expensive private healthcare system in the world. Private hospitals' prices in South Africa are on par with prices in countries with much higher GDP levels, such as the UK, Germany, and France, which makes it unaffordable to the masses of our people, who happens to be predominantly black in general and women in particular. In other words, the private health care sector in South Are only meant for the rich. This means that the public health sector is deemed to be for the poor. This is a two-tier system of health provision, which is highly inequitable and unaffordable. In fact, I can go as far as calling the present system as anti-developmental. The current state, as reflected, cannot be left unattended by a caring government. Hence, the process towards the establishment of the National Health Insurance is necessary. The advent of the National Health Insurance will ensure equity of health care in that members of the public, regardless of their socio-economic status, will have the freedom to seek health services from any accredited care facilities, whether public or private, and there will be no need for them to pay out-of-pocket expenses. Access to quality, affordable health services will therefore be on the basis of need, not ability to pay. Vulnerable groups such as women, children, older persons, people with disability, orphans, and rural poor will be prioritized. This will save hundreds of lives of people who are left to die because they cannot afford to pay for healthcare services. The Honorable Minister has indicated the figures and the cost. Both the National Development Plan Vision 2020 and the World Health Organization agree that a well-functioning and effective health system is the backdrop for the attainment of universal health care for development. This view is further entrenched in the Sustainable Development Goals 2030 vision, especially goal number 3, which states that ensure healthy lives and promote well-being for all at all ages. With the target number 3, which states that you must achieve universal health coverage, including financial protection, access to quality essential health care services, and access to safe, effective, quality and affordable essential medicines and vaccines for all. Honorable Chairperson, the 1978 Alma Ata International Conference on Primary Health Care declared that government have the responsibility for health care of their people, which can be fulfilled only by the provision of adequate health and social measures. Primary health care addresses the main health problem in the community, providing promotive, preventive, curative, and rehabilitative care, which includes promotion of food security and proper nutrition, adequate supply of safe water, and basic nutrition. Primary health care is therefore the basic foundation for universal health care. One of the key pillars of primary health care is community participation. Community participation enables individuals to become agents of their own development instead of being passive beneficiaries of development aid. The engineering of primary health care is therefore an appropriate service delivery platform. We want to take this opportunity to congratulate the Department of Health for what they have done in this regard. It is important to note that the key principle of the re-engineering of primary health care systems are a population oriented to health, meeting the priority health needs in a comprehensive manner, improving health outcomes, and well-functioning district healthcare system with a focus on upstream factors that impact on health, the social determinants of health. With respect to the social determinants of health, the ANC government has managed to a greater extent to provide basic services such as no-fee paying schools, social grants, free and subsidized housing, clean water, electricity, sanitation, and free primary health care. The provision of these services to address the social determinants of health over the past 22 years of our democracy and freedom have shown huge improvements in the lives of many ordinary South Africans. The progress made in the 3 streams of primary health care re-engineering is highly commendable. One of the key game changers at the primary health care level has been the deployment and expansion of the ward-based PHC outreach teams, which has registered an increase from 1063 teams in 2013 to 2,000 teams in 2015. Members of the ward-based PHC outreach teams have visited and profiled 407,990 households since 2012, reaching over 2 million people. Another key component of the PHC reengineering is the Integrated School Health Program, which is collaborative efforts between the Department of Health, Basic Education, as well as Social Development. This reflects intersectoral collaboration within government. The department has procured and distributed 70 school health mobile vehicles to 11 NHI pilot districts. The department has managed to increase the number of schools health teams from 425 teams in 2013 to 435 in the last financial year, and with an intention to increase it to 600 teams over the MTF period. These teams have since managed to screen a total of 679,728 grade 1 learners for physical barriers of learning such as eyesight, hearing, speech, and oral health. We urge the department to fast-track the process of acquiring the services of speech therapists, audiologists, opticians, and dental practitioners to provide these services as they are urgently needed by these learners. We also welcome the progressive step taken by the department to seek to transform all public health clinics to ideal status through Operation Pakistan. This model is aimed at improving the infrastructure of our clinic based on the philosophy whereby each clinic is purposefully built in that different sections of the clinic are specially designed to deal with acute care, mother and child, and chronic care, with each having its own waiting areas. This approach will enhance the functionality of PHC facilities greatly and improve the patient experience, for example, by reducing the waiting times. This model is based on the primary healthcare approach, which is in line with the Alma Ata Declaration. This approach has been proven to be the most effective system of providing a better health care service. We need to do everything we can to strengthen primary health care, as illustrated by Cuba, which has them among the best health outcomes in the world. In this context, Chairperson, that is why this year, as the Deputy Minister has indicated, we are celebrating 20 years of a formal bilateral cooperation between our country and Cuba in the field of public health. As a result of the SA-Cuba agreement, cooperation in the fields of public health and medicine science, there are currently about 3,000 South African students receiving medical training in Cuba. Unfortunately, they don't include the Western Cape. So far, more than 490 South Africans from previously disadvantaged backgrounds have graduated as medical doctors, providing much-needed primary health care services in the most rural areas of Limpopo, Northern Cape, Eastern Cape, and KZN, to mention but a few.
Please conclude, Honorable.
This cooperation is within the context of the spirit of what the late President Samora Machel said, and I quote, "International solidarity is not an act of charity. It is an act of unity between allies fighting on a different terrains towards the same objectives. The most of these objectives is aid development of humanity to the highest level possible." And I close the quote. Conclusion, Chair, a healthy long life for all South Africans, as the vision of the department, will be possible by broadening and deepening community involvement and social mobilization in all aspects of our life. We therefore urge the department to make sure that they mobilize society in the form of clinic committees, hospital board, and make sure that they become part of the process so that we are able to strengthen our health system and make sure that we make a health system a viable solution and a process that mobilizes society as a whole. The ANC support this budget vote. And
Thank you very much. The Honorable Minister, you are left with 3 minutes.
Thank you very much, Chairperson. Thank you, honorable members, even for the proposals that you have made. Ndatem Tlhongo, let me come with a brotherly advice. It's very clear that the speech was prepared for you. Nothing wrong with that. We all have our speech prepared for us. But when a speech is prepared for you, during a debate, You will listen and move according to the debate. You don't just read the speech as it was written originally. I just announced that South Africa has appointed its first ombudsperson, Professor Malega Puru Makgoba, last week. And in your speech, you just read a complaint about the absence of ombudsperson because it was written last week. The second issue about CCOD, go to Ask NUMSA, AMKU, NUM, UASA, Solidarity, how the CCOD changed the life of mine workers when it started compensation. And I want to invite you for their conference on the 20th, where you'll hear about most of these things. The other thing I want to mention, Honorable James, some of the proposals you made about your alternative for NHI are already in the NHI white paper. Please go to read it, like section 309. I want to make a few more announcements, Chairperson. In December this year, the Nelson Mandela Children's Hospital is opening up, and we want to celebrate that. Our icon has built us a world-class hospital, not only for children of South Africa, but for children of the whole region, and it's opening officially in December. The second thing, Chairperson, I've been asked, there's been a debate here, I can't remember by which honorable member, that information is not reaching our people about their health needs. That is very correct, but please be patient. We are about to unleash a communication campaign called PILA, Inspired to Live. Just wait, you are going to see what it has got for the nation. The other announcement, Chairperson, I spoke here of an application, an app called STG, Standard Treatment Guidelines, which I said even honorable members can offload. That STG has already been offloaded 15,000 times by health professionals in South Africa and 1,000 times by international. The reason that I'm announcing this, it is a homemade system done by our own Medical Research Council here at home. It is not from England or from America, from Europe. It's homemade, but internationally it is in demand. And I want us to celebrate that because it's a very important thing. Lastly, Chairperson, Honorable Dudley mentioned the issue of expenditure, that we are spending more than all the other countries but getting very little. That is already in the white paper. The reasons are simple. 5% of that GDP is going to only 16% of the population. And the World Health Organization, OECD, has said so. That is the simplest reason why we are spending more but not getting results. We are spending more on fewer and fewer people and less on more and more people. And that is why we want NHI to bring that to an end. Honorable Dr. Volming, the committee by Professor Mayosi did not fall from the air. I commissioned it to do the findings that you are talking about because I saw a problem. Everything that we've mentioned here is from a committee that I appointed to do exactly that and to unveil. And I can tell you we are implementing the report of that committee, and I'm going to make sure that everything is reported. Thank you very much.
Thank you, Honorable Minister. Honorable members, you are reminded that the debate on Labour budget vote will take place at 2 in the National Assembly chamber, and a debate on basic education budget vote will take place at 2 in the Old Assembly. That concludes the debate on the business of this extended public committee. The committee will now rise. Thank you very much, honorable members, for your input.